Hello. Okay. Good evening. Good evening.
Recording
everybody.
in progress.
Good evening, everybody. So we are here again to discuss with a very, very important topic for which we require some specific knowledge regarding the diagnosis, management, and also its specific complications. So without wasting of time, I'm handing over the mic to our renowned orthopedic surgeon, teacher, Dr. Indirect Chapter. He will highlight its importance and we will start our program. Dr. Indirect Chapter, please.
Yes, good evening, everybody. This is, we are going to discuss Lisfranc fracture dislocation. You must be wondering why, after all the major fractures that we have problems with, why you've chosen one which is only confined to a portion of the foot. The reason is simple, is because this 20% of these Lisfranc fracture dislocations goes undiagnosed. And it is a difficult one to diagnose. It has to be examined clinically with a high degree of suspicion for any midfoot injury. And together with that, there has to be other investigations like X-ray, CT, MRIs, and what may seem perfectly innocuous may result in a very great difficulty in the patients when they are untreated and they go out to their mobility, weight bearing, walking, etc. And so much so that in the later stages, it becomes more difficult and the results of the operations are unpredictable. So here we go on the Lisfranc fracture dislocation. The key thing is to have a high index of suspicion. And we have very eminent speakers who will be talking about all this and who will be, we have Dr. Anandapal will be moderating. And we have persons like Dr. Amitavanaran Mukherjee, Dr. Nirmal Lode, both are highly trained foot specialists. And together with that, we will have others to join in and give their opinions. Amongst them, of course, is Dr. Swarnendu Samanto, who needs no introduction. He is actually is well known for his arthroscopic and pelvic trauma management. But he also has a very keen interest in these sort of orthopedic things. So we are all expecting an excellent evening this, and more important, an instructive evening, and so much so that we take the resolve not to miss this fracture ever again. So it's over to Ananda to start the meetings.
Thank you, sir, for a brief introduction and highlighting its importance of our gathering. So, the audience, so we are very much excited for the coming another 1.5 hours, so that we will discuss about the overview and the specific case discussion and all the advantage, disadvantage, pros and cons of management of this Lisfranc fracture. So without wasting time, I'm inviting Dr. Nirmal Lode. He's the eminent orthopedic surgeon of Calcutta. He will discuss about the overview of the Lisfranc fracture dislocation. Over Dr. Nirmal Lode.
Thank you, Professor Anandapal. Thank you, Indrajit sir. Thank you for the introduction, and thank you. I think this will be a great evening. So without much ado, I think I'll move on to this brief overview of the Lisfranc injury, and I'll put through an update so that you can have a flavor of what's going on, what's the recent update, the recent technologies down the pipeline coming over. And I think you're going to enjoy this evening with us. So welcome all the participants to this webinar. And also request you to put your questions so that you will be able to answer them at the end of the session, or we'll take questions in between. So with that, I think let's kick off. So this is the brief introduction, which I'll just put forth for your understanding. So I think the colored bones, the bones are colored here to verify, to again emphasize the 3-column concept of the foot. There is a medial column, the intermediate column, and the lateral column of the foot. Now, coming to the injury mechanisms. Now, this type of injury, can happen because of direct as well as indirect trauma. In direct trauma, as you can see, is this American footballer player. The foot is firmly fixed to the ground, and there is a force which is acting from behind to push the metatarsal out of its socket articulation with the cuneiforms. Also, fall from height can also result in a forced abduction in the post hyperdorsiflexion injuries. So which again pops the metatarsal out of its articulation with the cuneiform, stable articulation of the cuneiform, and resulting in a Lisfranc injury. So the mechanism could be either hyperdorsiflexion, which is commonest, or it could be hyperplantar flexion and a forced midfoot abduction injuries. Now, indirect injuries can result from ligament injuries as a fall from stairs or twisting mechanism, and also there are other mechanisms involved beyond this, as fall from height, motor vehicle accidents, in which this trauma is often missed, and to the extent of 20 to 40%, so which results in high litigation. So make sure when you have a polytrauma patient that you examine the patient as a whole, and you also examine the foot. And I'll show you the physical signs which you should not miss on the clinical examination, which can point to your diagnosis of Lisfranc injury. So they are commonly missed. Also, brief anatomy. You know, the second metatarsal is wedged completely in between the first metatarsal, the medial cuneiform, as well as the intermediate cuneiform. So when this sling injury happens as with a high velocity accident, the metatarsal base pops out. There could be other injuries as well as the metatarsal neck fractures, cuboid fractures, and injuries elsewhere. So make sure you have a proper diagnosis, a proper clinical examination, a proper thorough X-ray, and also CT scan to support your diagnosis. If not, then also do an MRI scan to support your diagnosis. So coming to the physical examination part, the first thing that you can ask the patient is to, when you palpate, you will feel a tenderness in the Lisfranc area. There could be a lump, there could be a swelling, there could be tenderness when you palpate this Lisfranc area. If you have a palpable lump or swelling, then have a high index of suspicion that this could be a Lisfranc injury. The second thing, the key sign to look out for is your plantar ecchymosis sign. So do not forget to look on the plantar aspect of the foot and look for the ecchymosis, which is a pointer again for your Lisfranc injury. You could also do some other tests like stress examination. We could do a midfoot pronation or an abduction injury. It could be painful in certain cases. So it might be difficult without anesthesia. But if that movement is painful, so have in mind, bear in mind that this injury could be the result of a Lisfranc trauma. The other thing which you can do is that you can hold the second metatarsal and do a ballotability test, the piano key test. This could also lead to a painful metatarsal if you have a ligamentous Lisfranc injury. So the key note which I want to stress here is do not forget to look on the plantar aspect of the foot and do note for the plantar ecchymosis, which is a telltale sign of Lisfranc injury. Also, you examine for the neurovascular status, the pulses, and the neurological examination. And these injuries are often, even in open fractures, you have a high incidence of compartment syndrome. So make sure you have a high index of suspicion about these kind of things. Now, when you have passed the physical examination, you'd like to do some X-rays. You'd like to do some X-rays in the AP plane, in the lateral view, as well as 30-degree internal oblique view. So make sure when you do an X-rays, if possible, do a weight-bearing comparative X-ray. So the weight-bearing comparative X-ray gives you the subtle difference when in certain cases when the diagnosis is not. So if you look at the left-hand corner, you can see that the foot on the left side, on the right side, this one has an aligned metatarsal with the medial border of the intermediate cuneiform. Also, the first metatarsal is aligned with the lateral border of the medial cuneiform. But if you look to your left side, there is a diastasis between, there is a translation, there is a shift between the intermediate cuneiform and the second metatarsal base, which should arouse your suspicion and ask you to seek further investigations like stress examinations or an MRI scan or maybe a CT scan. So look for the diastasis in this area, a loss of alignment, which is quite obvious in the third metatarsal also. That will arouse your suspicion that there is something going on in this area. So look for the shift or translation, do a weight-bearing X-ray, and do not forget, if in doubt, to take comparative X-rays of the foot. And when you come to the lateral X-ray, this is obvious, where the metatarsal has popped out of its articulation with the cuneiform, and there's a loss of alignment with the cuneiform. So this one is pretty obvious. So when the diagnosis is in doubt, if you feel that you want to investigate further, you can do a CT scan. A CT scan will give you an idea of the extent of comminution going out at the metatarsal bases. It can also give you an idea about the incongruity, about the loss of alignment of the bones in the foot in the medial, lateral, and the intermediate columns. Further, if you want to have an evaluation, if you want to evaluate the Lisfranc, the ligamentous Lisfranc, so you can do an MRI scan. And when you order an MRI scan, make sure you tell your radiographer, you tell your radiologist that to specifically look for the Lisfranc's ligament. Otherwise, you might miss it in the scan. It's a robust ligament connecting the intermedial cuneiform to the second metatarsal base. And if you look for it, it should be clearly visible as a dot structure. And this ligament is the strongest ligament connecting the medial cuneiform as well as the second metatarsal base. So that's the only connection that we have in this area. So again, comparative X-rays, just summarizing things. When in doubt, have a comparative X-rays. Make sure you have a weight-bearing X-ray. And if you think that you want to go further and investigate a purely ligamentous injury when in doubt, before you plan your treatment, so you can do an examination under, say, anesthesia, under live fluoroscopy. You can do a stress examination where you can abduct the foot and you can see the opening of the metatarsal bases with the cuneiform. So that will give you a concrete proof of your ligamentous injury. Also, this examination unless is a dynamic examination compared to the CT scan, MRI scan, or the weight-bearing X-ray, which is a static examination. Now, coming to the classification. So this is the classification put forth by Hardcastle and Meyerson in the year 1999. So types A, B, and C. Now, type B is the one which is most difficult to treat and has the worst prognosis. So this is again an overview. Type A is the one where there is some incongruity. Type B is partial incongruity. And type C is the divergent one. Beyond this, you have the ligamentous Lisfranc's. Now the Nunley classification of 2002. In stage 1, there is a sprain of the Lisfranc ligament. In stage 2, there is a disruption with diastasis of the Lisfranc's ligament. But on weight-bearing X-rays, the arch height, the medial arch is maintained. In type C, in stage 3, the ligamentous arch is gone in addition to the diastasis and the rupture of the Lisfranc's ligament. So this is just an enumeration of the Nunley and the Vertillo classification of athletic injuries. Now coming to the treatment part. So once you've established that this injury can be treated non-operatively because there is no instability, there is no disruption, the joints are aligned, and on stress examination, everything is stable. So when you have a ligament sprains, that is Nunley and the Vertillo type 1 injuries, you can perform a non-surgical treatment. With the joint step up, the diastasis is less than 1 millimeter, you can try this treatment and without dislocation instability, like I mentioned. So the treatment is like initial weight bearing for 6 weeks in a plaster back slab, followed by gradual conversion to weight bearing in a cast or a walker beyond 6 weeks. And beyond this, I think we shall discuss as surgeons, we shall discuss the surgical or the operative. Now the question here is to whether to do an ORIF and fix the Lisfranc's ligament, fix the joints in stable fashion, or whether to do a primary arthrodesis and avoid a second operation resulting out of the primary fixation, where you need to remove the hardware at the end of 6 months. So I have put forth some indications for ORIF, where the aim is to anatomical restoration of the length, the axis, and of course, to maintain the joint congruity. So remember one thing, when you fix the medial column, take your attention to the lateral column and make sure that there is no instability, no fracture, no compression in the lateral column. So you need to address all the columns when you are looking at this type of injury. So ORIF can be performed in case of primary fracture dislocations, where there is less combination, as is evident from the CT scan, in younger patients and in low demand athletes. Now you could vary your indications and you could go on to do a primary arthrodesis in more comminuted fractures, high demand athletes, in primary ligamentous injury, in overweight patients, in revision cases where there is failed ORIF, and in advanced age, like I told you, where there is no need, where there is need to avoid the second operation. So this is a brief overview of the ORIF. So it's a dual incision approach. So make sure you place your incisions as wide apart as possible, so there is enough skin bridge between the two incisions, and you do not undermine your skin edges or do not pull traction on the skin edges when you're operating in these kind of cases. Otherwise, this would end up with a horrible plastic surgery situation. So you must remember one thing before I proceed further here, is that the first, second, and the third are the firmly fixed joints. Although the first joint has some degree, 5 to 10 degrees of mobility, the second and third are firmly fixed, and the fourth and the fifth are mobile joints because they need to adapt the foot to the surface. So you fixed rigidly the first metatarsal to the medial cuneiform using the screws or extra-articular plates. And the next in order, you use your home run screw, that is a Lisfranc screw. You can use it from either direction once you have compressed and stabilized and reduced congruently the second metatarsal to the intermediate cuneiform. And you hold it with the reduction clamp before you drive home your screw. Your screw could go from the medial cuneiform to the metatarsal base, which is a smaller target, or vice versa. There are papers indicating that if you go from the second metatarsal base to the medial cuneiform, which is a much wider target, and in cases also broken implant removal cases, this approach could also be easier. So you fix your first, you fixed your Lisfranc ligament, and then you fix your third metatarsal to the lateral cuneiform. So once this is firmly fixed, you divert your attention and reduce your fourth and the fifth metatarsal to the cuboid using K-wires. Now, as regards hardware, you can use a 3.535 vertical screws or a 4 mm screws, or you can use some variable locking screws, level locking plates, which are available in the market now and is widely used. So here is a picture where you have fixed first metatarsal to the medial cuneiform, and you use the home run screw to fix your medial cuneiform to the second metatarsal base, and then you have fixed your stabilized your second metatarsal additionally to the intermediate cuneiform, and the third metatarsal to the lateral cuneiform, and fixed your fourth and the fifth mobile base using only K wires, which could be removed later in the hospital or the clinic and the outdoor department only by just pulling off the K wires before the patient bed gears. When you plan an arthrodesis, you reduce your joints, you denude the articular cartilage, you can put in some bone graft, and you primarily stabilize the first, second, and the third, but use only K wires for the fourth and the fifth because they are the mobile articulation of the foot. So here is a case example. This gentleman, middle-aged, about 50 years of age, he had a crushing of the medial cuneiform as well as the first metatarsal base. So I had to do to distract this medial column, get it out to length to reduce the shortening, and pull it out to length, and then stabilize this first metatarsal to the medial cuneiform using an extra-articular plate, and then using a Lisfranc screw to stabilize the medial cuneiform to the second metatarsal. And I did not remove the hardware in this case, and the gentleman has been well since. So he's been 3 years down the line. I have no news of him now, but I assume he's doing well. This is another case of young gentleman, aged about 30 years of age, an active runner, and he had this ligament injury in a vehicle accident. Here also I've used an extra-articular plate after reduction, as you can see here, to bridge the first metatarsal to the medial cuneiform, and then the second metatarsal to the intermediate cuneiform. I did find some intercuneiform instability in this case after the reduction of the first and the second raise, and I used a screw to stabilize the cuneiforms together. So I'll show you some innovations from arthrex.com, also video on arthrex.com. So here are the special plates. They'll be shortly available in India from arthrex.com. This is a 4-corner fusion wherein you fix this second metatarsal base screw, and then you put a screw in the medial cuneiform. And this screw, what it does is to compress these two bones together. They bring the two bones, metatarsal bones, and the medial cuneiform together, and then stabilize the second metatarsal in the mortise. And then you can go on to fix the first metatarsal base to the intermediate cuneiform. The one below is the arthrodesis plate. It's down the pipeline. So coming back to the algorithm of treatment. So when you have a Lisfranc injury, you first determine by physical examination and by X-rays and CT scan that whether it is stable or unstable. If it is stable without dislocation, then like I told you, you do a boot cast for 6 weeks and then allow the patient weight bearing up to 6 weeks. Whereas in high energy trauma in open fractures with dislocation, I think you can go in doing a primary ORIF, and in certain cases of subtle Lisfranc ligamentous injury, where by stress examination you find that it is unstable, or it is dislocating, or there is an articular step off, or there is a linear translation, then you go on to do an arthrodesis primarily. Coming to the complications, compartment syndrome is one which is not to be missed. You have to have your eye and always, a high index of suspicion of compartment syndrome, because the results of compartment syndrome could be disastrous. There could be infection, thrombosis, a midfoot deformity, and an arthritis owing to non-anatomical reduction. This is another point which I want to stress here, emphasize again and again, which is of profound importance here, that you must reduce your second metatarsal in the mortise congruently. Do not have an incongruent reduction and go on to fix your fracture. You must, in an ORIF, you must do a proper anatomical reduction. And like I mentioned, type B injuries do worse than A or C. That is the Hardcastle and the Meissen classification. And there is a need for secondary fusion in about 10% of the cases with complicated Lisfranc injury. Thank you for your attention. I'll go on and ahead and play the video for you. I think, is my screen visible to all?
Yeah, all right.
Okay, fine. I'll just go on and play the video from arthritis.com.
Is the Lisfranc internal brace stabilization. So what we have is we've already performed the dissection. So we want to be able to identify
We can't see the video.
Video is not coming, Nirmal.
Video is coming.
Base of the second metatarsal.
Hang on, just
No, you have to answer. You have to answer from the PowerPoint, then directly go to the video.
So, okay.
Identifying where the second metatarsal base laterally is coming in.
Again, you share the screen. You share the screen in a correct way, and then
Just share the screen now.
yes, please share the screen. And
So are you able to see the video?
still not still.
Are you able to see the video?
Yes.
No.
Yes or no?
No.
No. Okay. So
You start your video first, then you share the screen. Start your video, you minimize it, and again share the screen, and then we'll start.
From Kansas City, and what we're going over today is the Lisfranc internal brace stabilization. So what we have is we've already performed the dissection. So we want to be able to identify the lateral base of the second metatarsal. So this is that proximal lateral base of the second metatarsal right here. So this is where we're going to start with
যেমন খুলেছিলি নির্মাল্য তেমন ভিডিওটা বার করে খুলে শেয়ার কর
clearly identifying where the second metatarsal base laterally is coming in.
you able to see the video now?
Yes.
Okay, fine.
Situation.
Fine. Great.
Yeah, so Dr. McCullough from Kansas City, and what we're going over today is the Lisfranc internal brace stabilization. So what we have is we've already performed the dissection. We want to be able to identify the lateral base of the second metatarsal. So this is that proximal lateral base of the second metatarsal right here. So this is where we're going to start with our button. So now moving on to placement of our guide wire, affecting the neurovascular bundle, but then clearly identifying where the second metatarsal base laterally is coming in, and then utilize a K-wire. So certainly in the situation where there's an injury that's present, utilization of a reduction plan, which is going to parallel the direction in which you're going to place this guide wire, something that you want to have placed. So similar to what you're seeing there, that's the trajectory that we're trying to achieve with this K-wire, trying to hug the proximal lateral aspect of that second metatarsal base. Center on the Lisfranc articulation, and in particular in regards to the second and the first. Now we're coming through medially with our guide wire, a small incision here to allow us to over drill our guide wire. And this will allow us to expose the proximal medial aspect of the medial canal. This drill is uniquely set up to allow you to just drill in 15 millimeters to avoid any violation of the Lisfranc articulation. And so you take that guide down the bone, and drilling over the top of your guide wire, flush that down. So at this point, what we're going to do is we're going to advance our guide wire through. So we're only just a small portion of it is remaining dorsally. So now we will load the collagen-coated fiber tape into a small 9mm eyelet, and then only advancing about an inch of that. having already drilled this, you can simply just advance this through by hand. So now you can see where that button is sitting right along that dorsolateral cortex. You can see the track of our fiber tape as it's going through. Next, what we'll do is we'll turn immediately to be able to secure the fiber tape in place with the swivel lock, making sure you're down the bone. And that swivel lock right over the top of the table. You can now see in that same area where we had the diastasis previously. This is now where this frame has now been reduced and secured. And so with this technique, what you're going to do is subperiosteally, making sure that you're deep to the extensor hallucis longus. You're going to go over the dorsal aspect of the medial cuneiform to then identify where your fiber tape is exiting the bone medially. Using the hemostat to do that. You're going to feed the tails of the fiber tape to yourself. And bring those over dorsally, just like we're doing right now. Go ahead and drill. And so then you load the 3.5 swivel lock onto your fiber tape. And similar to what we discussed with our last fixation, you would have a clamp in place holding this reduced. And so then approximating what the length is, and mark the laser line on the fiber tape. And then you finish your swivel lock into place. So now you have a knotless construct that not only stabilizes this frank articulation right in here, but you now also have the ability for any proximal bearing stabilize that from your more plantar medial exit from the medial cuneiform now dorsally into the intermediate.
Yeah. Okay. I think I'll stop screen sharing. So I think one of the usefulness techniques, one of the loopholes that we have with the primarily this tightrope technique is that there was osteolysis close to the bone, and this hardware loosened out. So that is one of the primary defects, primary drawbacks with this technique. But I think this reinforcement with the internal base, I think this is working. This is working great because you have reinforcement to your primary tightrope. And secondly, you could also use a washer to reinforce this osteolysis problem to get over it. So this is the way I think the tightrope problem has been overcome. So I think Swarnendu sir would agree with me. If you can give your benign inputs on this one.
Yeah. Most of the time, whenever I do the Lisfrancs, to be very frank, I always open it, see it naked eyes, because if I do it closed, most of the time, as you told, it is more than 90%. Even if it is look good in the image, you are not basically reduced. So reduction has to be perfect, and your suspicion should be very high unless you take the proper weight-bearing X-ray or the ecchymosis in the undersurface. You must see that tenderness is there. Whenever I am going to put anything in the Lisfranc, I will always put the screws, not with the K-wires, and see it naked with open eyes.
Yes, I think
I have never used the internal brace for any of my Lisfranc till date.
Okay, but this is an augmentation of the internal brace, I think. So maybe we can give it a try because the results are coming up in a great way. So other thing is for the postgraduate trainees is that I think they're attending this session. One of the signs that you have to see on the X-ray is your flex sign. So also remember, there's a small chip of bone in case of ligamentous injury or a bony chip fracture, just medial to the second metatarsal base. So that is also
Flex sign is pathognomonic. Flex sign is pathognomonic of Lisfranc, and this way you have to have very low threshold for your CT and MRI. Otherwise, you may miss. It is a very low threshold for the CT and MRI.
A quick comment from Indrajit sir on this and Professor Anandopal.
Yes, Dr. Sardar. So
from both of you.
Yeah. That was a very comprehensive thing that you have said. The thing is that I think several other modifications of the classifications are coming in which they are getting a D category also to detect the very difficult or the subtle or the occult Lisfranc. Very often we may not find the flex sign, or we may not find other things. And one of the key things which we have found, the problem for us is that we get things late and severe injuries is the piano key sign. You push and push and extend and flex the fingers, and that leads to and that's only in subtle cases. It's not the obvious ones which are there. and which you often find the open and everything. So that is more obvious. It's only in the where you have a suspicion, but you are not quite clear on it. That is the second thing. And I think it's been a very comprehensive overview of the everything. And when we go on to the cases, we can discuss the other things. As you said, the plates that are available are quite expensive. So we'll have to think about doing the other plates which are available and which are there. The thing to mention is that the discussion about cancellous, the cannulated screws, I think that also should come in, because one of the easiest thing to do would be to put in a KY, check on both views, and then put in a cannulated screw. You're there all the time. But the problem is that the cannulated screws are not so strong. So that's which way you go, which way you decide is another issue there. But the main thing is that what you've emphasized perfectly is to have a high index of suspicion. And let's not miss these fractures. These are there. And since we know that they're there, we have to make all the methods that if we have a clinical suspicion, we go ahead and do everything required, CT, MRIs, whatever is available, what is required, stress views, the stress tests, everything to bolster our clinical diagnosis.
Exactly. Thank you, sir. Another important point I want to add. So there is sometimes there is some plantar displacement of the metatarsal. So not only always there is dorsal displacement, but also there is a possibility of plantarwards displacement. So we'll be very much vigilant about it, especially for the lateral view and the oblique view also. And another important factor is there's only lateral Lisfranc, only the lateral part. There is intermetatarsal. There is increased gap between the third cuneiform and the fourth metatarsal. So that space may be increased, and that may be easily missed. And even in absence of the classical Lisfranc lesion, that part of the lesion is always equivalent to the same injury that may be missed along with the other major injuries, along with the other parts of the foot. So that has to be looked at. That is, I think, that has to be missed. Another important point is, along with the Lisfranc fracture, there is a possibility of severe hematoma inside the foot that may lead to the compartmental pressure. So if there is some compartmental pressure, that may jeopardize your functional deficit if it is missed, and usually that has to be evacuated by the same incision as we are opening. So we have to very much vigilant about. So these three things, I think, it should be added. Anything added from any other panelists? Dr. Mukherjee, and Dr. Pan. Dr. Mukherjee.
Yeah, I can just.
Can I?
Yeah, Amita, go ahead.
It's absolutely comprehensive. Only one thing, a small reservation you can say. One is, as Nirmala pointed out, tightrope has certain things to say that there is osteolysis and some tightrope reaction, oblique infections are there reported in 4 or 5 UK studies. What do you think, Nirmala? It was in. So
yeah,
there was.
I think they have a reported incidence of infection that is a result. It fell out of favor.
Yeah,
and now I think the authors come back with this reinforcement of the internal brace. But we have no experience of this, but I'm sure with Arthfix.com launching its products in India, we might have an experience going on with this stage. At this stage, I'd like to ask all the panelists, there are a few questions from the participants. Can we take them at this? There are 4 questions. So Professor Pal, I think we can take this question.
Yes, we will take the questions. I think please put all your questions to the chat box so that I can find it out and I'll throw it towards the panelist. And I think Dr. Shardar he was telling something.
Yeah. Please, Indra, please. Sorry to disturb you.
A comment, then we'll go to the cases.
Yeah, just to point out this, that why are you fixing the medial cuneiform to the second metatarsal? Because it's absolutely important that there is no intermetatarsal ligament between the first and the second metatarsal. So
Yes.
to stitch the first and the second together, you have to put the cuneiform to the second. That's why this these oblique screws coming from top, that is so essential.
Exactly, absolutely right. That is the anatomical problem, and so anatomically this there is deficiency of this intermetatarsal ligament in between the first and second. That is why the stability of the medial arch is solely dependent on the Lisfranc ligament. So we'll come and highlight this problem. So without wasting time, I'm inviting Dr. Anjan Pan. Dr. Anjan Pan, are you ready? Dr. Anjan Pan?
Yeah.
Yes. Please share your.
Just to interrupt, there's some background noise coming from somewhere from somebody. I wish you would please. It's distracting.
Can you see this?
Yeah, Anjan. Yeah.
Can you see the slides?
No.
We
Hello?
can see you, sir.
Okay.
Sir, you are visible. Can you share your screen?
No, slide is not coming, Anjanda.
That's why I'm asking.
Sir, one quick comment about Indrajit sir's this cannulated screws. Sir, there is a high incidence of breakage of the cannulated screws. I think they should not be used because there's a high incidence. The textbook does not recommend. So I think for the participants, I think it is useful. It's always better to use a 3-5 screw or a 40mm screw or the extra-articular plates, but do not use the cannulated screws. Correct me if I'm wrong, sir.
Yeah, absolutely right. That's why the cannulated screws went out of fashion. It's easier to give for the surgeon, but it's not so good in the long-term results. You're perfectly right.
If you put them, you have to take it out on 3 to 4 months.
Yes.
And it is visible now?
Yes,
Yeah,
sir.
yeah, Anjana, it is well visible. Well visible and audible.
Okay, thank you. So there is a lot of repetition, but I'm going first to this. So it has already mentioned there is a large oblique ligament, but it is 3 times stronger than the dorsal ligaments of these metatarsals. So clinical assessment is the most important here, because for that reason I emphasize on this. The pain in the midfoot, running and jumping are impossible. Localized pinpoint tenderness based on the first and second metatarsal. Ecchymosis sign, bruising under the arch of the foot is often finding. And provocative test is pain in side-to-side compression of the midfoot, pain in dorsal and plantar deviation of the first metatarsal head while stabilizing the second metatarsal. That is the piano sign. This ecchymosis and painful movement after holding this thing, and this piano sign is positive. So imaging is the X-ray, AP lateral and 30-degree oblique parallel to TMT joint surface, and another is 15 to 20-degree cephaloid view. It is very useful when the pain is too much, weight bearing is not possible, then this view is very helpful. And also the weight bearing X-ray, CT scan and MRI is not very much essential in these diagnoses. So standing AP is good stress test. So it is shown this non-weight bearing and weight bearing. And stress radiograph in adduction and abduction, which is usually under the anesthesia, you can do these things. And assessment is the diastasis of the first and second metatarsal, first and second cuneiform diastasis, widening between second and third metatarsal, widening between middle and lateral cuneiforms, and small aversion fracture, that is flex sign, you know already. And loss of parallel alignment of the medial border of the second metatarsal to the medial edge of the medial cuneiform is the most important. And in sagittal plane, malalignment of metatarsal joints in lateral X-ray is also very important. So you can see it in the third stage. You can see that this fourth metatarsal is in the line of the first metatarsal when the diastasis is 2 to 5 centimeter more, and this loss of longitudinal arch height. So this is most important in lateral X-ray. You have to check it always. Aims of the treatment is pain relief by enhancing stability, fusion in functional position, and plantigrade foot. So in non-operative treatment, that is the NSAID, activity modification, local steroid, steep sole shoes, rocker sole shoes, full length steel sank, and orthotics, UCBL and hinged AFO and carbon foot plates. Carbon foot plates is using, so it's minimize the pain very much. So in non-operative treatment nowadays, carbon foot plates is a good option. And in the operative treatment, the option is the first is reduction. If you go, reduction is in everything, or you go for VRIF or infusion. So open reduction in internal fixation, suture button, breech plate, and screws. And if you go for primary fusion, then with screws or plate. So VRIF has a role that is in no medical comorbidities in the patient, high level of activities, younger patient, smoker, or risk factors for non-humans. And the fusion has a role in the diabetic, older age group, more severe injuries, intra-articular comminutions. So primary tarsometatarsal fusion is better outcomes by Lee and Corsi, and lower rate of reoperation in one and done, that is in Henning et al., and less sensitive to time from injury, also Henning et al. And Kuchar et al. Consider VRIF if lower energy and acute energy and maximum mobility is important for we are going for the VRIF. Some of the joints are non-essentially rigid, that is in the red color. So we can go for arthrodesis in this part. So there is not much of movement. And essential mobile is this joint, these green lines. So these we can not fuse usually. So fusion only what is painful. Otherwise don't fuse that one. Most likely the medial column, the first tarsometatarsal and navicular medial cuneiform, second metatarsal and navicular medial cuneiform joints, plus minus third joints. Don't fuse fourth and fifth tarsometatarsal joint, it is mentioned already. But there is a big thing, that is don't forget the gastro. Because if the gastro tight is there, you should have to release that one. Otherwise pain will not go. The operative principle is K-wire for temporary fixation, used cross screws, dorsal compression staples, or dorsal locking plates. So dorsal bridge plate from this rectangular, and the medial and dorsal bridge plate. Along with these, you can use this internal brace also. Or you can use the internal brace and then put the bridge plate. After that, if the athletes are heavy athletes. Another trick, screw fixation. When you are tightening these screws, dorsiflex of the toes, while tightening these screws, reduces the gap of the joint. So always you have to remind this thing during the operation. So Lisfranc internal brace he has shown in the video and other thing, but here only the internal brace is not good enough. So you have to do this over the top fixation. So you have to bring the suture tape under the tibialis anterior and the extensor hallucis longus and put it in the intermediate cuneiform. Then swivel anchor screws is fixing on the internal intermediate cuneiform. Then it will be stable, and it will stable also the medial cuneiform and intermediate cuneiform mobility. So post-op, it is mini fluoroscopic decrease, radiation exposure, full thickness closure with suture, leave in for 3 weeks, elevate foot, well padded splint, cast for 4 more weeks. X-ray at 8 weeks, 12 weeks, and 20th weeks. Additional follow-up is 18 weeks and 24 weeks. So post-operative care is 0 to 6 weeks, immobilization in a non-weight bearing cast, 6 to 12 weeks, K-wires removal, partial weight bearing in a walking boot, gentle range of motion exercise, 12 to 20 weeks, full weight bearing in a hand sole shoe, or bicycling, hard sole shoes, and bicycling, swimming are encouraged, and 20 weeks screw removal and gradual return to sports. I have shown one case, that is 55 years old lady had twisted injury in left foot. They treated with NSAID, crepe bandage, and ice compress for more than 3 weeks. Then she came to me with persistent pain while walking. These are the picture, the stress view. So we have to operate. First, I am putting one screw from medial cuneiform to intermediate cuneiform. Then I put this H plate, just like this bridge plate fashion, and fix all the four corners. And this is the 16-month post-op. The pain has gone, everything is all right, but he has a pain in the lateral side. But he thinks that it is due to this pain in for these plate and screws. But she has a rheumatoid arthritis. The seronegative rheumatoid arthritis. I think for that reason also. But even then, she insists for removing of this plate, and we remove the plate after 2 years. And with the DMRD and other things, he is well now.
Sir, go back to your slides. You go back to your slides in the first case. Case one. Can you just case one? No. The previous. Can you go back to the beginning? Yeah, that's it. Sir, there's a hole in there. Sir, did you feel the need to do any other additional investigations at this stage, apart from the weight bearing X-ray, to rule out bony injuries or a nutcracker cuboid anywhere else for the benefit of the audience? If you can just tell us.
Under anesthesia, you can do these manipulation tests. If it is painful, then you have to do it.
No CT scan, no MRI scan in your case.
No.
Nutcracker fracture the cuboid, anything else to see the lateral side?
No, because if it is cuboid fracture, then you can show it in the later on X-ray. It will be visible.
Okay, so you only did a weight bearing X-ray in this case.
Yeah, definitely. Because that time there is no pain in the lateral side.
That'll go up. Okay, sir. Thank you, sir. The next question is: Could you just tell us, if you go back one slide further? Can you advance one slide to the operative side? Next slide. Yeah. Yes. Sir, here I'd like to ask you, for the benefit of all, could you, sir, please mention your sequence of fixation in this case? What was your sequence of fixation in this case?
I told you that I first put the medial cuneiform to intermediate cuneiform, and then put the H plate.
Okay, so you reduced your second metatarsal base.
But always I put the K-wire first and then put the screws.
Okay, and I believe you also find some intercuneiform instability because you have put an intercuneiform screw in this case.
No, when you are using this bridge plate, this type of bridge plate, then intercuneiform, then the home run screw is not necessary.
Yeah, I was saying this intercuneiform screw that you have put here. The intercuneiform screw that you have put here, because you found some instability here.
First of all, I thought about this more instability in the cuneiform. So I put the medial to intermediate cuneiform screw. And then I thought that I put the H plate. So H plate or rectangular plate, whatever you like. So I put that one because I want to give a supple foot for that reason.
So these H plates are strong enough to hold the metatarsal base in the mortise reduced. Are they strong enough? Because from the looks of it and from fixation of it, I feel maybe the prongs could have been a bit wider apart, get a better hold in the first metatarsal base, the second metatarsal base, as well as the cuneiform C1 and C2. So do you feel any way? Or
it is also the second, first, and medial and intermediate cuneiform. All four corner has been well stabilized. If you see the X-ray.
Anjan, I have one question. That is the sequence of screw fixation in the plate that you did.
In plate,
first where, second where?
First in the first and second first. And the first metatarsal, then second metatarsal, then this medial cuneiform and intermediate.
So the metatarsal you fix first, and then you go on to the cuneiform.
Then I come to the cuneiform.
Okay. And you removed the case at the end of 6 months, I believe?
No. In that case, I removed it after 2 years because she is not athlete. She is doing everything well, so I don't. But she has to walk a lot.
Sir, you also mentioned that she is a rheumatoid patient. Did you mention that?
Yeah.
Sir, in rheumatoid patients, do we have to take any additional precaution, any additional fixation do we have to take? I mean, delayed weight bearing, some protection. So, what are your thoughts on the rheumatoid patient for the benefit of all?
No, if it is depends upon the bone quality, not for this rheumatism. If your bone quality is all right, then it's not necessary whether it is rheumatoid or not. But maybe for that reason, he has some joint pain and other things will be there. But about the fixation, you don't need anything more.
Okay. Sorry. Sir, please go on.
I think.
Hello.
I think this case represents one of the things why the Lisfranc has to be fixed. You see this 2 years later X-ray, there is no midfoot arthritis. All the joints.
That is the advantage of ORIA.
Yes.
Above the fusion.
Yes.
But if necessary, you can do the fusion in the older age group and other things, or if it is too much of combination.
Yeah, after 2 years in a rheumatoid, you've got this amount of nice joint space in the midfoot. That looks very good.
Really remarkable. Swarnendu sir, I'd like to bring your attention at this point, sir. Your quick comments. Anything you want to add to this presentation?
No, I think this is the perfect sequence for whatever Dr. Anjan Pan has done, because this is the sequence we do it. And you have to first, as because he could find that there is some inter-uniform instability, he has fixed the medial and the intermediate, then he has fixed the H plate. And the sequence of screws, whatever Dr. Sardar was asking for, I think that is the sequence you put your screws. And if the guy is young and you have to remove this, if he is going to run and jump, then you have to tell the patient beforehand that at some point of time, probably at 4 or 5 months of time, before he regains full jumping and all these running activities, you have to remove the screws. Otherwise, it might break.
That is all the patients I have always tell that it might break. Before operation, you have to say that.
Yes, before operation, you have to tell that I am going to remove these screws by around 4 or 5 months of time. When the purpose of this thing is healing is over, I think you have to tell the patient. Otherwise, they will be rather surprised to see that why doctor is again asking for the screw removal. It has to be like your AC joint hook plate, that you have to tell by 8 months, 9 months time, I have to remove the plate.
Okay, Ananda sir, can we advance to the next case by the next speaker? Sir, can you unmute yourself? Ananda, can you unmute yourself? Ananda sir, please unmute yourself.
Dr. A.N. Mukherjee, please be ready. So in the meantime, just I want to share that this experience is this. The strength of this plate is extremely good, and it is almost stability is almost equivalent to fusion. And another important point is, unless the patient is an athlete and having some complaint, that can be kept for at least as long as possible. I think if it is done in the middle aged or in the even after 50 years, I don't think it is needed to be removed. I think so. In older age, I don't think it is needed to be removed, because it provides extremely sound stiffness, sound stability to this middle longitudinal arch, I think. So what is your opinion, Dr. Sardar or Dr. Pan, regarding is it required to be removed in all cases, or that can be kept in the...
No. Only for the athletes and runners,
yes,
then we are telling that your screws should be removed. Otherwise, it will hamper your sports activity.
Exactly.
Yes. For the young people, you have to remove it. Yeah, not for the middle-aged and the inactive people. You don't have, even the guy is sedentary, you don't have to remove it. Even if it breaks, it is like your Syndes foot is
exactly.
Doesn't matter. Yeah.
Yes. Okay, Dr. Mukherjee, are you ready? Dr.
Yeah, I'm ready.
Anando sir, can we have one quick question from the audience, from the delegate, from the participant for Dr. Anjan Pal. So Dr. Amit Rai, I think he has asked this question: can these screws hold up if the patient is overweight or rheumatoid or does weight bearing jobs? So that is a question from Dr. Amit Rai, Kolkata. For Dr. Anjan Pal, sir.
It can be continued because I have removed it after 2 years when he has insisted me. I am not going for removing that screws. He has insisted me for this removal of the screws. For that reason, I removed them.
So the message is that the screws are holding up pretty tight, but in case of overweight, you talk to your patient, you deliberate with your patient, and then urge for removal, implant removal before you weight bear. Otherwise, you can keep these implants in situ, but do keep a close watch with X-rays and follow them up regularly. So that is the message.
Definitely, always.
Okay, sir. Over to Amitabh, sir.
Good evening. Am I audible?
Yes.
Can my slides are visible?
No.
You cannot. Slide share is there or no?
No.
Oh my God. Again the same issue.
No issue. Just do slide shares. I think it will.
Trying. Thanks once more. Okay. Is that okay now?
Yes, it's coming.
Yes, it is coming.
Yes.
So, is that okay?
Yeah, make it full screen. Yeah, that's right. Excellent.
Fine. To start with, good evening to everyone. Is the second phase of lockdown. So we are locked back again. So sharing some of my unconventional way of treating Lisfranc's injuries, as in the way I have been always a point of controversy every time. So I'm putting myself again in the back in controversies. I'm putting some controversial issues. So starting with about the Lisfranc's, as everyone says, if I'm not give my hats off to Jacques Lisfranc's of 1786 to 1887, he was an basically Napoleon's French surgeon. He was a gynecologist, and he was the one who found out in the cavalry patients in 1885 these injuries happened. So when these soldiers used to trip off from the saddle, keeping their foot entangled in the stirrup, they used to get these injuries. And that is the time when this gentleman, Lisfranc's, went through a lot. And these injuries coincidentally used to lead to a vascular injury. A lot of them has to go on midfoot amputation at that time. So that was the time when Lisfranc's discovered this injury. And this is the story how this Lisfranc's injury name comes from this gentleman, French surgeon, and he was a good gynecologist also. And by doing this, just adding a bit spice to this, he could do a midfoot amputation in, trust me, in 2 minutes. That's in record. In 2 minutes it could do, because he know these are the line. If I chop up from there, the foot is off. So whatever may be, let's go to the next slide. So as everyone said, some old things, that's Lisfranc injury, Lisfranc's ligament, as you all know, base of second metatarsal to medial cuneiform. Injury caused separation of the first and second metatarsal, leading to forefoot instability. This is the place where, just one sec, this is the place where the instability happens, as we all know. So coming to the next one, so the injury is referred as a Lisfranc's if there is any disruption of the tarso-metatarsal component. Injury has range of sprain to the Lisfranc's ligament, dislocation due to ligament tear, and fracture also. Many a times it's also fractures which leads to Lisfranc's injuries. Why this area of the foot? As everyone has pointed out, no transverse ligament, so I don't need to go for much it. So minimal support increase the risk of injury. There is the minimal support in that place, so there is the higher risk of injury. So the X-ray, I'm talking of very basic things. We have CT scan, MRI, everything. So X-ray, AP, lateral, plus minus oblique. So here is plus
Amitabh sir, you are not audible.
I think there must be some internet issues, network problem.
I think he had some issues. In the meanwhile, can we take some quick questions from the
Yes,
participants?
yes. Nirmal, go ahead with the questions.
Yes, yes.
am I audible? Am I audible?
Yes, please.
Your permission.
So,
Because many a time it's the
Yes, yes.
please share again. Please share again. Please
I have to share again.
Yes.
Yeah, because the internet went off, I think.
Okay. I'll try. Just bear with me.
Because of the rain and because of the rainy season in some rural area, the internet is not proper.
Ah, Sarnandu, rural.
Yes, it is visible.
Yeah, go ahead.
It's visible now.
Yes.
Pardon me to be a person of a rural area. So I'm really presenting things as a rural way. So, কি জানি বলিস স্বর্ণেন্দু? কি জানি কথাটা বাংলা কি বলিস? যাই হোক. So we'll come subsequent. So am I audible? Am I audible?
Yes. Audible and visible also.
Okay. So X-ray finding is maybe it's absolutely normal, but you must have a high range of suspicion because it is the clinical assessment which gives you the thought behind it that there is a Lisfranc injury. Does it moving? No.
It's not moving.
I think
You double click on this slide. Double click.
Okay.
Yes, it's moving.
Move.
This is again the same problem.
What? Now it's fine?
Yes.
Yeah, this is.
Acha. So as I said, the weight bearing view widening more than 2 millimeter between first and second metatarsal base indicates at least ligamentous injury is present. At least the ligamentous injury is present. As Swarnendu said, and many of us, our friends said, the flex sign, the avulsion of the base of the second metatarsal, represents the rupture of the Lisfranc ligament. So coming to the metatarsal classification and the nodal classification, as Nirmallo has very widely pointed out. So they had the total incongruent, partial incongruent, and divergent. So I will today, so just to fast on cases on this, then I will try to show you some partial incongruent, which are a little bit rare and treated in the rural way, the way as Swarnendu says. So, and the coming to the nullness classification, this is stage 1 and stage 2 and stage 3. The most important part is here. Here is the Lisfranc ligament sprain, and here is the diastasis, and here is the diastasis and loss of the longitudinal arch. Now, coming to the next, the case 1, as all of us has seen. So I'm not going to much of it. So there is the type A, so which has been used by 2 screws, and that is the normal way. We generally, the easiest way.
We lost you again, sound.
I think, sir, we'll take one question at a time here quickly. So, Dr. Somnath Manna has asked a couple of questions. What is a Lisfranc injury and the definition of it? Sir, Anando, sir.
Yes, yes, it is discussed. What is Lisfranc injury? That is the already discussed, and it is.
Am I there?
Yes.
Sorry.
Share again.
Yeah, sharing again. I know. People will.
I think the definition is already given. That is the injury of the Lisfranc ligament, which is basically traversing the medial cuneiform and the base of the second metatarsal. And so that is the basic things of the classical Lisfranc injury. I think you already highlighted, So I think this is just the point is how to diagnose it. There is clearly it is diagnosed. It is discussed by you and also Dr. Pan and also Dr. Mukherjee also. There are another question is Tushar.
Am I
yeah, please carry on. We'll come again.
No, am I visible and audible?
Yes, visible are both. Yes.
Oh, thank you. Again, the same problem. Oh, so this is a standard way as we treat. As I said, I have taken a chance how to treat this patient on baseline level. I thought there will be so this is a type 1 injury of incongruent variety, which has been treated by 2 screws. See the congruity, and this is a very old, it's maybe more than 10 years old case of mine. He is working, doing everything. This is another case, the pure home run screw. See the type A type of injury, fixed up. See the space is obliterated. There is not much screws. This is also around 10 to 12 years old case. As you can see, find out this is the old X-rays. So, but I am more concerned about what Nirmaldo says, the rare variety, the partially incongruent. So you can see this case. You can see the foot. The foot tells you where you are. Now you come to the X-ray. Can you see the base of the first, Anando, first metatarsal?
Yes, it's clearly visible.
And you can see the fracture, you can see the gap. That is actually the same of the type B1, that is medial partial incongruent type, which is, I could see 3-4 in my lifetime. So how to treat this? Because these are different. All this, is my cursor is visible? My cursor is visible?
Yes.
So this part is more or less okay. You don't have to do anything in this part, in these cases. So you are only concerned about this part, first metatarsal base. So I have gone through some of the literatures, and this is one of the case of the lockdown time when I didn't have much of the things which were possible and had with me at this time. So now I come to the next. How did I treat it? So this was the way I treated. So this was on the plaster, one home run screw and another screw fixing the fracture transversely. You could see this. You could see the difference of the space and everything. And this is the case which I have to do in lockdown period. This is one of the case, not much of the implants were there. So this is one of the case done with a CC screw. What the point which we were discussing. So, but there was a problem. I could not have a pocket cut. I generally, when we put the home run screw, Nirmal, as you know, we made a pocket cut so that the screws get embedded. But I could not do this. But I had to because this. So this is 4 months follow-up. See this, the popping out of the screw head. Can you see? Yes. Can you see?
Yes.
Because I could not bury the screw down. But he is able to stand, sit, squat, and do everything. This is just, I think I asked him to come this 3 months and I asked him to walk. This is just 3 months. Now I give the people to think how he walks. Can you see?
Yes.
There is little bit of larch is there. It's just 2.5 months, but I intend to take off this screw. Can you see the video?
Yes, it is. Yes.
I intend to take off the screws as early as possible. Maybe I have asked him to come and I will take it locally in my next room. And the next is the case 4. This is the another one. That is the lateral subluxation. This is the X-ray. So this is trace view. This is around 10 to 12 years old patient. This is the another rare variety where the whole chunk of this, they slides laterally. That is laterally partial incongruous. This is a fracture base of second metatarsal, fracture base of the third metatarsal and fourth metatarsal, and fifth metatarsal has slipped down. You can see all these things. But first metatarsal is in place, very much in place. So that was the thing. And this foot was it came to me around 2 weeks old, and I'll show you the status of the foot. That was the foot, how it was looking like. It was 2 weeks old. So there was a dilemma. Should I open? If I open, can I be possible to close the skin? You see the skin structure, and should I leave it? If I leave it, this will be too old. So what I did, again, I said, it's something controversial. I don't ask everyone to do this. So under anesthesia, so this was this time. This was this time. Can you see? This was partial or total lateral. I could not say it was, it may be a total lateral, but partial lateral was not there because the fifth metatarsal was also slipping down. I am getting back a little bit. I think this was total lateral because fifth metatarsal was also a little bit slipping down. Anand, what do you think?
Yes, it is almost completely, yes, it is total.
So total. So what I did, it was little bit in the other way. That was, I fixed all them with K-wires. So initially I reduced them with, I have a technique of pulling these toes with my little bone holding forceps, tie the toe fingers with the gauge, and on the top of the gauge I hold them and then I pull them. Otherwise it's very difficult to pull a finger or thumb every time booby trap or Chinese trap is not available with us. So that was the initial fixation. You could see, firstly, I reduced the whole thing, and from fifth metatarsal, I fixed up to the base of the first metatarsal, the cuneiform, put in K-wire. Then I gradually put these K-wires and reduced all these fractures. And that was the way. You can see this was to get the whole damn thing fixed on the medial side, and this was put in, and then the next K-wires were put in. And that was the final moral structure. And then I advanced this K-wire up to this. And this was the clinical picture at the time when I put the things on. And trust me, this is 10 years follow-up of this gentleman's foot. This is the 10 years follow-up. You can see the K-wire marks. K-wire marks. Rintu is not with me, but he used to take this all wonderful records. These are the marks. This is from the other side. This is how the foot looked like, and this is the video, how what he said.
Yes, it is excellent. Dr. Mukherjee, I just want to know, so how did you feel any difficulty to reduce, because it was already 2 weeks old?
Nearly 2 weeks old, 7 to 10. So what? That's what I said. It's really difficult. So without doing it open, I just give you a trick that how do you hold? Because holding the foot, forefoot, and get the midfoot reduced is the most difficult job. How do you hold the forefoot? You have to hold the forefoot and then you have to reduce the midfoot. That is the most difficult. So what I do, I have forgot to take that photograph. I have this small bone holding forceps like you use for the radius holding, the serrated one. So you take the fingers, wrap them up with gauge pieces, and then you hold it and make the tighteners tight. And then it becomes a gross tight thing, whole thing. And then you pull it. And then you pull it and it reduces. And that's the way I reduced it.
Okay. So does you start to pull it from second toes onwards or from the fifth onwards?
I initially pulled from second, then third, then fifth. Once I put all them, I generally put 3 bone holding, in this case 3 bone holding clamps in all the fingers. I started from them, then I gradually pulled it up, and like milking, I used my thumb to milk the base of the fifth metatarsal to put the whole thing back. Putting a milking pressure on the base of the fifth metatarsal, I put the whole thing back.
Okay.
So thereafter, I put the K-wire from fifth metatarsal onward to fix it up. Yeah. This is something which I have to do without much of knowledge on this and how to do it.
Absolutely right. That is a nice technique. So that is why the point is rightly taken, that unless you loosen all the relatively all the fractures at a time, so it is very difficult to correct the shift, lateral shift. So we have to loosen all the little bit callus or anything or any tissues which is concentrated at the fractured side, and we have to loosen simultaneously all the fractures at a time. Otherwise, it is very difficult to fix the shift, the lateral shift. So first loosening all the fracture side, then they have to fix the from lateral to medial K-wire, followed by fixation of the second, third, fourth. I think this is the sequence, isn't it?
Yeah. If I say it like this, you start pulling from here,
Exactly.
here, and then you milk it.
Exactly.
With your finger, you milk it. So all the thing falls in place.
Yeah, got the point. That is a nice technique. Okay, anything to be added from our panelist?
Ananda.
Yes.
Hello, Ananda.
Yes.
Look, if you saw this foot, what do you think? It's maybe a compartment syndrome.
Yes, maybe it's a compartment syndrome.
It may be a compartment syndrome, but it is not.
Yes.
Because nowadays they said that there is no such compartment syndrome in the foot.
Okay.
Because whenever you open or you can put the K-wire or anything, then these collection of the blood will go out.
Yeah,
so there is no need of to do this compartment syndrome for this fasciotomy and other things in the foot.
Okay.
That is the nowadays trained.
That is a good knowledge. Yeah, that is excellent. And anything to be added from our panelist, Dr. Shardar?
No, this is good. Actually, I want to go back to the previous X-ray that he showed. And there are two types of screws being used. One screw is that the proximal is non-threaded and the distal part is threaded. The other is all threaded. So the discussion which I would like to focus on, which screw would be the best in these situations.
Dr. Mukherjee?
Yeah.
Please.
Can you show?
Should I go back to my slide sharing?
Yeah.
The previous X-ray.
Indra konta bolon?
ওই ফার্স্ট কেসটা
ও আচ্ছা এইটা তো
Yes.
তুমি দেখো একটা হচ্ছে থ্রেডেড স্ক্রু থ্রু আউট,
এই যে এটা আবার কি হলো 10 তারিখা দাঁড়ান, একটা ক্যানুলেটেড স্কুল ছিল ইন্দ্রদা, আমি বলে দিচ্ছি আপনাকে।
হ্যাঁ
দাঁড়ান কোথায় গেল 2 তারিখা, এই তো
that's right.
Can you see? Yeah.
Home run screw is a cannulated screw, I think.
Yeah. Now both of them are cannulated. You can see this part is plain and this part is plain.
No,
See, please.
So both are distally threaded, right? So
both are distally threaded.
Okay, so I didn't see that initially, but the discussion which I want to say, apart from the cannulated part which you've discussed, when you should you use a fully threaded screw or these sort of screws?
Should I say something? I use this partially threaded because I thought partially threaded will have little bit more strength than full threaded. If I have this much of part non-threaded, that will be, there is always a chance of junctional failure at this place, but at least this part is more or less solid than this part. That is the, ideally this screw should not be used, but I use this on this biomechanical support of my head.
What are the views of the other members of the panel? Fully threaded screws or partially threaded?
No. I think when you are using it for an acute scenario, you can even use the fully threaded screw, because thing is that you are because whatever screw length partially thread you take, definitely it will be in the joint side. So even if you take the fully threaded screw, I think it is not going to make much of difference.
No, you need some compression in the joint.
Yeah, because if you need some compression in the joint, then probably you need the partially threaded screw. But the problem is that if you have to have that whole thread part going to the proximal part, otherwise there is no compression, no?
Yes, Swarnendu sir, if you see the threads are not entirely in the medial cuneiform. The threaded portion is not entirely in the medial cuneiform. So it's
Yeah. So that's I'm pointing. That's I'm pointing to. If you don't cross the threaded part to the completely in the medial cuneiform, basically you are not having any sort of compression. Basically now it is working as a position screw now.
No, therefore, you can use the distal threaded part as a small distal thread.
Like So, then you have to use the small thread, small part distal thread. Then only it will compress it.
And if you are using a fully threaded screw, as is being used in most cases, do you overload the proximal cortex?
Yes, if you want to compress it, you have to over drill the proximal cortex so that you can have the lag effect.
Yes.
Also use a countersink.
Countersink, pocket. You are talking about this one.
Yeah, where your case the screw head is prominent.
Yeah. No. Full threaded means you are talking about this one. Indo da ita bolchen to.
No, fully threaded screw.
No.
You drill the proximal cortex. সেটাই বলছি।
না আমি বলছি আপনি ফুললি থ্রেডেড বলতে এরকম বলতে চাইছেন।
এগুলোই তো ম্যাক্সিমাম ব্যবহার
করা। হ্যাঁ, that's it.
এটাই
Amitabh, you can go back to your first case where we had this discussion. So go back one slide previously. That's it. Hold it, sir. If you go back to your primary injury, eta aage slide tak if you can just go. Yeah, that's it. If you hold it there.
Yeah.
Sir, I'm asking all the panelists, what else could have been done differently, sir? What's your opinion? What else could have been done differently apart from the screw osteosynthesis?
Yeah, please.
There is always scope of the plate osteosynthesis. Yes, that's the
dorsal plate fixation can be done.
Yes, dorsal plate fixation. Yes.
Extra-articular plate. Bridging plate. You can also use some mini fragment screws to hold that fragment.
Even in this case, you can use this medial plate also.
Yeah. One the interfragmentary screw along with the screws, that is dorsal extra-articular plate.
Yes, completely agreed, because this is a big bony chunk. So I think if you just go ahead only with the screws, then it is a real not that strong scenario. So it is better to use the plate here so that you can have the better hold over there.
Sir, if I can just comment. Sir, see, there is combination of the metatarsal base. There is also some degree of shortening of the first metatarsal ring. So you can use a distractor to pull it out to length, hold it in position, then you open up. You can use some mini fragment screws on the mini fragment 2-7, I mean. You can lag that fragment together, and then you can use an extra-articular plate to fix the first metatarsal, arthrodes the first metatarsal to the medial cuneiform.
That is my opinion. That could be done, yes.
Yes, because this is basis community is a big fragment, it is better to have a better hold with the plate and screw.
Yes, also if you look at the second metatarsal to the intermediate cuneiform, I don't think the Lisfranc's ligament has gone ruptured. It seems to be quite stable. Although I am not sure whether this is a weight bearing X-ray or not. But it seems to be stable, so I don't think you can use a screw to replace the Lisfranc's ligament here, which sir has not done. So I think possibly there was no Lisfranc disruption.
Yeah.
Was not there.
No, Nirmalo, you may know, by the thing said that you might not having a Lisfranc's ligament injury, but if you have an injury like this, only fracture, that itself call upon the day for a Lisfranc's injury. You may not have an plus or plus minus of the ligament injury. Even you see this medial shift of the partial increment there, see this so you may not, so that's what you are truly said. That's what I have not given a screw here.
Yes, so I think it gives us to another important point. I think when we have this sort of X-rays and we are not able to do a weight bearing X-ray, so when you have the patient on the table, you can do an examination under anesthesia.
Anesthesia, absolutely.
Reveal all the spectrum of injuries that you're having in the foot, so that you can plan your incision, plan your approach, and plan your fixation accordingly.
Exactly. So at this juncture, just we discuss about the questions asked by Dr. Somnath Manna. What is Lisfranc injury? And that is basically little bit different. That is any injury of the tarsometatarsal joint from the first to fifth. So that is also included in the Lisfranc injury. And as it is, this is slightly mentioned So this sort of fracture at the base of the first metatarsal, along with some disruption of the first metatarsophalangeal joint, this is also included as a Lisfranc injury. Okay. Is there any other comment on this Lisfranc injury?
No, I think they have to understand the basic anatomy. Where is the Lisfranc ligament? If the Lisfranc ligament, they understand the plantar surface, it is there. Whenever there is in the injury to the ligament, either it can be pure ligamentous injury or it can be with the bony fragment injury. So that is the classic Lisfranc injury. That is very simple.
That's Sir Sonand, they have given this photograph. And
another thing is that you can follow any of the classification, like your Queen-Kuss or the Mearson's classification.
Yeah.
It is all that. It is basically from first tarsometatarsal joint to the fifth of it. 1, 2, and 3 is the medial column, and 4th and 5th is the lateral column. So this is the whole tarsometatarsal joint. You know, that is the joint is known as the Lisfranc joint. So it is not only the first and second. It is basically from first to the fifth, as Dr. Mukherjee has already shown you the classification system ABC.
Okay, Anand sir, can we move on to
pardon? So we can go to the next case discussion.
Thank you. Thank you very much.
Thank you, Dr. Mukherjee, for his wonderful cases where it has enlightened our knowledge regarding the management of Lisfranc injury. And so we'll discuss about the third group of cases, and that would be discussed by Dr. Nirmal Deb.
So I'll start screen sharing now.
Yes.
So I think you are able to see my screen now.
Yes.
Okay, I'll just go full screen. So I think I am representing the cases on behalf of Dr. Kushal Nag. Unfortunately, he is absent today because he has an emergency to attend. So that is our viewpoint. So we'll take on this very briefly. So any disruption in the architecture or any fracture at the metatarsal base, first to the fifth, is a Lisfranc injury unless proven otherwise. So that is the dictum. And I've already mentioned the direct mechanisms and the indirect mechanism injury. And this is how the metatarsal base fractures. So you have to look out for the flex sign on the X-ray, weight-bearing X-ray, where you have a chip of bone from the base of the second metatarsal. And you do a comparison radiograph where you compare both the foot, you do a weight-bearing X-ray, and if in doubt, do a stress X-ray. So now you coming to the order of screw placement, recommended order. You fix the first, it could be any order that you want. It could be from the first, but the general principle is that you fix the first to the C1, and then you use the Lisfranc screw from the C1 to the M2, and then you have fixed the M2 to the C2, and if you find the intercuneiform instability, then you fix C1 and C2, use a screw osteosynthesis. But remember, like again I stressed, use K-wise for the 4th and the 5th metatarsal bases, do not fix them rigidly. So that is in brief. So coming to this case, I think these are the different screw configuration just to bear in mind the way you can fix, the order you can fix. But the general principle is that you fix first, second, and third rigidly, and the 4th and 5th in a mobile fashion using K-wires. And there's a choice of implants that you have. The X plates already mentioned by Dr. Anjan Pansar. I think it's a very good construct, and these are robust plates. I can give you very good fixation. I think these are from Syntex, widely used. So I would like to draw attention to the first case. This is a 25-year-old medical professional, and this is a road traffic accident. So I'd like to ask the panelists at this point about their viewpoint and how they'd like to progress from here. Beginning with Anandapal, sir.
Yes, that is I think it is a total displacement of the lateral side. Total displacement. So and also intercuneiform instability. As also there is some instability of the tarsometatarsal. I think is a total displacement of the lateral side. So that it requires some special investigation also. Especially in this case, we'll ask for the CT scan, because this sort of severe injury. There is also possibility of injury of the cuboid, also some navicular also. So I think if there is some inherent fracture which is missed in the initial treatment part, so that may cause deterioration of the functional deficit. So in this case, I think there is some severe soft tissue problem. So we have to take care of that. We have to little bit. So especially this case, we require some immediate external fixation. I think external fixation. So there are some distraction apparatus which should be fixed on the first metatarsal, as also the talus. So, on the medial side, especially, I mean, if it is also in the lateral side, if we cannot do initially because of the severe soft tissue problem, we can do the distraction, and we have to keep it elevated, and also the other supportive measures till the appearance of the wrinkle sign. And in the meantime, so after we do the CT scan, and we can plan. So span, scan, and plan. I think this is the rule in this sort of cases. And following which we will start the fixation, and fixation should be always from proximal to distal and from medial to lateral. I think this is my dictum. So that is to be followed.
Very comprehensive, sir. I fully appreciate that. Sir, coming over to Indrajit, sir. Sir, we have done a CT scan. We have looked at taken care of the soft tissue. I think there was a high incidence of soft tissue injury in this case because this being a vehicular accident, road accident. So I think we have put in a fixator on the medial side. We have done our CT scan now, and now we want to progress further. Sir, your brief or your opinion on how to progress from henceforth. So we are 2 weeks down the line. We have got the wrinkle sign. We have a fixator on the medial side, as Anando sir has said. We have reduced it partially. We have got it back in line. Sir, your progress, how to progress from here?
Well, this has to be an open reduction. There's no question about it. And we have to see all that, make that first and the fourth metatarsal in incision, reduce everything under direct vision. And then, provided there are no other things, we will first fix the cuneiforms with a transverse screw, transverse K-wire or whatever. And then on reduce all the metatarsals, and then go on to go by one into that. Use I think over here the plate would be excellent, and for the first, second, and the medial intermediate cuneiform, and together with that, one screw for the third, fourth, and K-wires for the fourth, fifth.
Yes, I think we need to get our cuneiforms together, make them into one unit, use a screw osteocentric for that, and then reduce our metatarsals to the cuneiform using either screw, but better I think use plates for that. Coming to Swarnendu sir. Sir, would you like to do anything differently out here?
No, it is not different. It is not different. It is everything is. I think it is protocol based. The best thing in this sort of Lisfranc injury anywhere wherever it is the second cuneiform, because that is the cornerstone. So you form your cuneiforms in the proper way so that it forms the arch. Once the arch is formed, then you realign all your fives. So for 1, 2, and 3, you need one incision in between the first and second. So you see everything in front. First, second, the 3. As I told you, the medial column has to be fixed rigidly. I reaffirm that medial 3 columns has to be fixed rigidly, and never fix the 4th and 5th rigidly. It has to be a flexible sort of fixation. So 1, 2, 3 rigid, 4th and 5th flexible. Sometimes if you feel it is a bit flexible with the K-wires, even sometimes there is a association of the cuboid fracture, you may apply a small J on the lateral side, but it has to be always very flexible. So this is the basic rules for your complex Lisfrancs.
Yes, I think we all agree that we have to use a plate osteosynthesis for first, second, and third, and then a K-wire fixation for the 4th and the 5th. So I preferably use a plate fixation for the first metatarsal with the cuneiform C1, and maybe a screw for the M2 and C2, and similarly a screw for the C2, C3, and M3. Okay, over to Amitabh sir. Anything you would like to add differently? You want to say something?
No, I have to leave for an emergency. Thank you all. And it was absolutely done. He is a master man, I have seen. So it's fine. And it was really nice to have a fine interaction in this evening. So to everyone, stay safe, stay well. Please pardon me.
Thank you, Amitabh, for your uninterrupted internet connection. It was really nice to interact with you.
And it was also nice to interact with a Grameen man. Swarnendu Grameen, I remember the word. Okay, bye.
Okay, bye. Okay, so Anjan Pan sir, anything sir you would like to add to this discussion that's been going on?
This type of fracture, if you want to fix it, then always see the gastro and release the gastro if necessary. Otherwise, it is difficult to fix these things.
Yeah, that is a good point to be noted. Yeah.
Okay, excellent, sir. So let's go ahead and see what how this fixation has been performed. So I think this is the way Kushal did it. So I think he's used a screw osteosynthesis for the first M1 and C1, and he used a plate for the M2, C2, and M3 and C3. So this is how the osteosynthesis was performed. I think this is pretty stable. Sir, at this point, I'd like to take comments from Indrajit Sardar, sir. Sir, what do you think about the first M1 and C1? Do you think it is adequate, or we planned for the plate osteosynthesis? That would have been more better or more robust, I think, more forgiving.
Well, I don't know the exact condition, but I think he compromised on this after fixing the first. He wanted to fix the M1 to C2, and an H plate probably would have done, but I don't know about the state of the cuneiforms. Maybe the cuneiform also looked a little bit shattered, so I'm not sure that it would hold a screw.
Yes, I agree with you, sir. I think here would have been a much better option. Over to Anjan Pan, sir. Sir, your H plate would have worked excellent here.
Which one?
H plate, your X plate.
No, because it has the second, third is also involved. So only H plate cannot hold all these things. But here you can use these first metatarsal to medial cuneiform plate, either dorsally or medially.
Yes, I think yes. Yeah, that's another new spectrum. Shonda, would you like to add anything to this?
Yes. I think it is a flimsy sort of situation on the medial fast cuneiform, fast metatarsal and cuneiform. It has to be much more robust fixation on the medial side. We all agree on that. Probably I am happy with the second and third because it is holding the things properly. But if you critically analyze the X-ray on the lateral side, the fourth and fifth column, it is not in. It's not been there properly aligned. So your lateral column is not been aligned and reduced. Okay. So you see the fifth one is completely been out from the border of the cuboid. So it has to be realigned on the lateral column also. So I think medial column has to be refixed with the fixed with the most robust sort of situation. Second and third, I'm happy. I am not happy with the fourth and fifth.
We could have revised this fixation using a plate osteosynthesis on the first metatarsal to the C1, and then K-bar fixation after proper reduction to the cuboid from the fourth M4 and M5. Is that correct?
I think if it is a fresh case, unless it is an old case, you can do. I think this is not been done by Kushal. Kushal will definitely do it much because his thinking process is much stronger than us, and he will definitely do the best possible fixation for this sort of complex injury. And if you go ahead with the classic protocol of fixing the Lisfrancs, I think you know that you have to fix with the first and second the robust way. Then you go ahead with some flimsies for the third and make it completely reduced to your naked eyes with your second incision on cuboid, so that fourth and fifth falls into the place of your articular surface on the cuboid. And if you feel, you can add a small J's as I told you earlier on the lateral side. Okay.
Sir, would like to add something to this? Sir?
No, I think Shonendra is perfectly right about the fifth metatarsal being displaced. I'm not too sure the one on the right, is it an internal oblique view? Because if it was so, then the medial border of the lateral cuneiform is more or less in line with the medial border of the fourth. But probably
yes, it is not.
It's probably not an internal
line. But anyway, I think would have done with K-bar fixation on the fourth and the fifth. I would have also done that.
Absolutely. That has to be opened, seen properly, and then reduced also.
Reduce it. Yes, Ananda sir, would you like to add anything to this?
I'm also very much square about the fifth and fourth and fifth metatarsal, and that has to be fixed at least by K-bars. That is one. And if there is no plate is available, and please there is, because of the bone quality may be poor on the medial side, so at least one screw should be placed from the medial cuneiform to second metatarsal, I think, in a cross fashion, so that I think that will give some stability. Otherwise, intermetatarsal screw, at least another one intermetatarsal screw, intercuneiform screw, another first cuneiform to second metatarsal base. These two that has to be added at least if there is no plate fixation. Otherwise,
yes, I think missing. Intercuneiform screw fixation is missing in this case.
Yeah.
Yes, I think that is another point to be taken here. Yes, excellent discussion. So I think we'll go on to the next case. We have some time. So shall I proceed here?
Yeah, please.
So I think this case is just similar to what Dr. Amitabh sir has shown. So the same one which is discussing previously. So this is another case of a 40-year-old female with a direct trauma to the foot. I assume this is a fresh case, and without looking, sir, at the post-operative X-ray, sir, can you I'll come to Sardar sir first. Sir, what are your thoughts on this type of injury, and what is your further management? How would you like to proceed here? Any of your special tips and tricks?
No, the reduction has been well done. This is basically a reduction of the base of the first metatarsal to the cuneiform. And I think, I'm not too sure whether he's used Hubbard screws for this. Probably. And once he's got a protection of this with the plate, so everything looks good. The other four metatarsals are in reasonable state, even though the X-ray is not that great. But anyway, I think this is a fair one. He has reduced the fracture with the screws, and then he has protected it with this strong plate.
Ananda sir, coming back to you, I think the use of a distractor on this media, especially on the first important, I think that would have really enticing for us.
That is always I do see the medial the arch of the connecting if you connect the head of the center of the head of the metatarsals, so there is a little bit the depression and there is a shortening of the medial mirror. So it is always easy to connect this with the help of the distractor. If you put a distractor in the first metatarsal and also the talus, that is very easy to distract it. So I always do this this one threaded there is a 2.5 millimeter sun screw on the first metatarsal shaft on the neck, and another one 2.5 millimeter sun screw or any K-wire to the neck of the talus and to distract it. So it's a small distraction. It is easy to make my job is very easier for reduction. So there is indirect reduction followed by the compression with the help of a small bone holding forceps, holding the fragments with each other, following a K-wire, small K-wire fixation, followed by this any sort of they use the Herbert screw, but any sort of screw may be helpful.
Yes, I think the general idea is to pull it out to length, get it distracted, and then reduce your articular surface with the help of a embedded screw like a short Herbert screw or any screw from mini fragments set 1.5 or 2 mm or 2.5. And then I think you can plan next whether to bridge it with using an extra articular. So I'd like to come to Anjan Pan sir, and like to ask him, sir, one of the indications for fusion was comminution of the base. So do you think this 40-year-old female patient, I assume she was without any comorbidities? So could you be used as, could you have fused the first tarsometatarsal joint? Would that work for you, sir?
If it is needed, you can do that thing. But here, I don't think fusion is necessary. Because with this thing, she will do good work. Number one. Number two, usually I am using Chinese strap traction. In these cases, if it is the fresh one, without giving this distraction and other things, because with the distractor, to putting the screw and other thing is very difficult. So if you use the Chinese strap traction, then it will be much more easier.
Yes, another.
I think Nirmalo, in this acute scenario, in this 40-year guy, you don't go ahead with the primarily with the arthrodesis. Okay, I think if the guy is young, suppose, then probably if you see the literature and if the people are now telling the results of arthrodesis is much better than the fixation. But for the sedentary type, and if you can fix the fracture and you can put the plate like this, I think this is more than enough for this lady.
Sir, but the one point is you have to remove this plate before the lady begins weight bearing. So what about that? So can you have a discussion?
Yeah. No, you can remove the plate. Not necessarily. Every time you don't have to remove the plate. Unless the patient is symptomatic, he is complaining with the plate for some irritation or everything. So you don't have to remove.
So I think
the plate is more in the athletes, not in the general people.
Yes, more in the athletes, more in the young. As I told you, they're athletes and runners. Then only you have to remove. Otherwise, for the sedentary 40-year-old lady, you don't have to remove the plate.
So there's no indication for plate removal. So
No. Unless he is symptomatic, you don't have to tell for the removal.
Okay, coming back to Sardar sir, commenting on the osteosynthesis, do you think the first ray has been pulled adequately to length? And what about the alignment and the axis of the first ray? Do you think that's okay?
It is a bit awry if you look at the joint surface as such, but it is a bit less. It is not absolutely perfect. The thing is that I don't think a distractor was used here. Even if you don't want to put in a distractor in a acute situation, you can use a thick K-wire given dorsoplantar and pull on that, and the first metatarsal neck or head or whatever. And you pull it and it'll do almost the same thing. That is, provided you have a strongish assistant. And,
yes.
And then you fix whatever is being done. And probably the first needed to be a little bit done. But it's
I think
arch is not too bad.
Yes, I think it is going little towards the midline, like here it is going to be to the towards the second, only because you see there is a lot of comminution on the lateral cortex. That's why it has gone to the midline, like it has been adducted. Okay, so I think if you don't use as Indrajit sir is telling, if you just pull with the thick K-wire, if you maintain the length, the best way probably would be like you're fixing a small J to maintain the length. And then you fix it, then you remove it.
But I think Anjan sir has also given us a trick. He is to use a Chinese strap and then pull it out to length. So that's another way of doing.
Yeah. That is
like to ask. Yes, like to ask you. So if you see there are 4 cortices fixation on either side of the fracture, do you think that is adequate, or should we use the general principle like 6 cortices on either side of the fracture? So your comments.
For this one,
there are 2 screws on the proximal. 2 screws, yes, on the distal fragment.
Yeah,
do you think that is adequate?
No.
Should we use?
This is adequate for this one. This is adequate for this one. As because you have already, as because you have already used 2 differential thread screw at the base, and then you have just spaced this with 2 screws on the proximal and 2 screws on the distal part. I think you are going to immobilize for some time, for 6-8 weeks time. I think this will consider it at that point of time. No problem.
Okay, point well taken, sir. Okay, so with that, I think with there are no more comments from the panelists. So we move on to the next case if I have something. So yeah, fine. So this is another 30-year-old man with a sports injury. So what we have here is a 30-degree internal oblique view. That is all we have. I assume that there is a Lisfranc's injury, ligamentous injury, because there is a shift of the second metatarsal base compared to the medial intermediate cuneiform. So there is a bit of diastasis going on between the first and the second metatarsal. I think it should be more than 2 millimeter. I assume this is also not a weight-bearing X-ray. Sir, to Sardar sir, how would you like to proceed from here, sir? Would you like to do any additional investigations, any stress radiography, anything else, MRI, CT scan?
I would definitely do a CT scan to see whether there is a flex sign or not. And probably an MRI would also help to know the ligamentous injuries, because we're dealing with an athlete. Now, then once there is a 2 millimeter greater than that, so this has to be fixed for the athlete. And for here, I would, I think that H plate would be an excellent thing to do in this case. Probably you can use that second metatarsal cuneiform screw and the others. But H plate looks very elegant.
Shamanta sir, would you like to do anything here for the further management of this case?
Yes, fast investigation that I do is the MRI. Because in MRI, you will get both the things. You will see the ligament, you will see the flake, you will see the bony element. So because this guy is high demand, then you should not miss any of the Lisfranc. Otherwise, he is going to blame you throughout your lifetime. So first you do that, see that what is the status, because from the X-ray we can jolly well appreciate this is the classic sign of Lisfranc. Okay, because this is not matching with the second cuneiform. So you have to fix it. Probably I disagree in one point with Indrajit that I'm not going to use the plate on the very first shot. I will just be happy with the 2 classic screws.
2 classic screws, not the plate. Okay.
Not the plate, yeah.
Okay, great. So coming to Anjan Pan sir, how do you like to proceed from here? Your comments.
But I am most.
We are planning for 2-screw fixation versus a plate fixation, as Indrajit sir has said.
I am also going for this plate fixation, not for this.
Plate fixation.
As he is athletes, so I have to remove the plate, and then it will be much better option.
Okay, Ananda sir, would you like to how would you like
to this is a pure ligamentous injury, I think. But there is also I will I will draw the attention on the lateral side also. There may be there is a space between this third metatarsal and also the lateral part of the third cuneiform also. I think there is a possibility of ligamentous injury on that side also. So in this case, as it is a patient is sports injury, sports person, 30 years, very young. So it should require a robust fixation on the medial side, either in the form of this this X plate, or otherwise internal brace will be the one, because if we use the plate, there is a question of removal at least after 3 to 4 months at least before, because there is always some pressure to return to sports. So we have to remove that. Otherwise, there is an internal brace is the ideal one, I think, in this case. And on the lateral side, if clinically, and also we have to do the specific investigation. If it is, we are very sure that there is a possibility of this injury on that, we have to fix it with the help of K-wire. That has to be removed at least after 3 months, I think.
Anando, but
okay,
if
so
you use the internal brace, then also you have to put the plate. That will be much better.
Yeah, that is yes. But always, if you are very much satisfied enough with the tension with this internal brace, in that case, it is only we can use along with some one or screw. But if you are not satisfied enough, then we can add the plate also. So it is, I think, it is a power-operative decision.
Yeah, interoperative. So I think the take-home message from here is to do further investigation in the form of weight-bearing X-ray. We'll also do an MRI scan to look at the ligamentous injury, ligamentous Lisfranc injury, because that will give you a diagnosis of what's going on in your in the midfoot. And also you have to look at the intercuneiform, whether there is instability or not. And thirdly, I think because this is all static examinations, I think per-operative, intraoperatively, we do a stress examination and we find out where other instabilities are happening. So once we have that in mind, so we can use a tightrope fixation with an internal brace augmentation for the M2 and C1, and the bridging plate fixation for M2 and C2. Is that correct?
Yes.
Yes.
Okay, so let's go on and see what the surgeon has done. So I think he's used an X plate. So the bridging plate he has used to fix this ligamentous injury, and I think this is without a tightrope because I can't see any drill holes. So I think this X plate is robust enough to hold the second metatarsal to the C1, and it is easy to apply. But coming back to Sardar sir, I think the sequence of fixation, I think that is very, very important, where you put a screw in the M2 first, and then you put a screw in the C1. That compresses diagonally reduces your metatarsal base in the mortise. And then you want to fix the M1 to the C2, M1 to the C2, the other side, diagonals of this X plate. So I think that compresses this metatarsal in the mortise. So Anjan Pan sir, is that the sequence? Is that correct? Your H plate will do that function for us.
If you don't fix any other screw in the cuneiform, then it will be okay. Otherwise, if you put one screw in the cuneiform to hold these medial and intermediate cuneiform, then you have to put the first distally screws and then proximal screws.
Okay.
Otherwise, you have to put the diagonal screws.
Coming back to Sardar sir, do you think this fixation is adequate with hold in this case of athletes?
I think so, but because you are not going to go ahead and more give him weight bearing, etc., or practicing on sports and all that for quite some time. So you have to follow the sequence of no weight bearing, followed by the cast boot and all. It should hold for that time and allow the things to stabilize.
No, I have got a question. I have got a question to Indrajit and Kanjanda. Suppose we are fixing this with the plate. What is it? Because the screw which goes from the fast. one. I think that is the robust most fixation for this. I think this is going to be coming as the ligamentous injury. So, is there any? Do you put the screws? Yes or no?
In the medial cuneiform to second
In the
metatarsal base.
in the ligamentous Lisfranc.
You can put the screws, but if you put the plate, the advantage is you are not damaging any part. So the ligament will heal automatically if you hold this portion without fixing this Lisfranc part. If there is any flex or anything, then it will hold automatically.
Okay.
Sir, I agree with Swarnendu, sir. I think the screw fixation has been pointed out also by the American Foot and Ankle Society. I think the screws are a very good, robust fixation for the Lisfranc ligament. I do not think the tightrope can do that work. So that was a conclusion of the meeting.
Okay.
So I think
you
are correct. I think that the screws replace the Lisfranc ligament, and I think that is a very robust fixation because that robust fixation the tightrope cannot give you.
Yeah, because only you cannot rely on the tightrope or the internal brace. You have to have the screw. Tightrope is just the supplement. As we repair the lateral ankle ligaments or the medial collateral of the elbow, we just give the tightrope. Even for the MCL in the knee, you give the internal brace only after having a proper repair and recourse. It is just having the external. It is just like act like a plaster, internal brace. So I don't rely on any way on the internal brace for the ligaments to heal. I will definitely put the screw. Then only probably I will supplement, but rarely, I promise you, I will never use the internal brace for my Lisfrancs.
But okay, all sense answer. I think the screw fixation here is also an alternative to this X-ray fixation. I think the screws can do the work. If you have a purely ligamentous injury, the screws can do the work. And sir, do you routinely remove screws before the patient weight bears at the end of 3 months? Do you do that after 6 weeks or 3 months? Do you remove that?
No. 6 weeks is too early to remove the screws.
3 months. I beg your pardon.
It is never before 4 months, 4-5 months. I think it is more than 16 weeks you remove the screws. If it is going to run, jump, and he is real. Actually, it should be like 20 weeks. Okay, never before 5 months.
So, do you remove the screws for weight bearing?
Yeah.
And sir,
no, never before 5 months.
For the ligamentous injury, we require some compression between this. So this compression is that is why for the sake of compression, screw is much more better than this plate because plate is almost acting like a neutralization device. So in that case, so that doesn't cause the compression between this second metatarsal and the first cuneiform. So in that sense, the screw is will act much better than that. But regarding the point of fixation, so if we consider the stability and the strength of the fixation, this sort of plate is better.
Okay, sir. So we are giving him a second operation by removing the plate. So is there any chance we can do a primary arthrodesis in this kind of athletes and then rid them of the second operation? Or to question to
Nirmal, basically you are opening a Pandora's box between the fixation and the arthrodesis because this is a big question, yeah. Because if you see the literature, the high-end athletes, the result of arthrodesis is much superior than your primary fixations.
Yeah.
So in the high-end athletes, so probably most of the foot and ankle surgeon probably they might be agreeing on rather than fixing with the complex Lisfranc with the arthrodesis rather than putting the screws because they are never happy with the fixations.
Yes, I think there's a huge debate on that. It's going through everything. And I find that they are more in favor of primary arthrodesis because the risk of you can avoid a second operation and they are very happy with the rigid fixation. They can go back to sports very easily. Sardar sir, at this point, sir, would you like to do ORIF compared to arthrodesis in this kind of young athletes?
Arthrodesis is something very definitive about it. You can't go back. In this case, what you need is for the ligament, etc., to reconstitute. And you'd want to do that without damaging the articular surface. Because if these are athletes who are now you're not arthrodesing, going in for just a ligament repair, then anything going through the articular surface is going to create problems somehow, somewhere down the line. Now the plate, this thing is a good one, and the reason why I was emphasizing so much on the fixation of the plate sequence. If you are putting the cross plates, one in the second and one in the cuneiform, the moment you tighten the screws properly, you are getting a decent compression on it without interfering with the articular surface. The rest of it is there to really protect those two. So in these high-level places, this sort of fixation would probably retain the first metatarsocuneiform joint and that, because I am absolutely not sure about what these high-level athletes would need. They will go back to sports and exactly, I'm very unclear about the functions of the first metatarsocuneiform bone articulation in these level of athletics. There are so many levels that they play at, exactly what sports they are playing, all these sort of things. So I would try and preserve the articular surface, allow the ligament to heal, see how it is going, and probably in most of the cases it will happen. The arthrodesis versus just the osteosynthesis is absolutely Pandora's box, Shannindu. It's a Pandora's box. This one goes that way, that one goes that way.
Yes, yes.
Really, we don't have the experience to recommend one or the other. So when
Yeah,
there is doubt in our mind, I would preserve the articular surfaces for the time being.
Then probably we'll refer to Anjanda for the special comment for as the foot and ankle surgeon. Rather, me and Indoda will put the screws and plates, and arthrodesis will be done by Anjanda.
There's one question from Dr. Gaurav Chatterjee. What are the appropriate X-ray views to decipher Lisfranc injury?
What is the question, Ananda? I could not understand.
The question was, that is, what are the appropriate X-ray views to decipher Lisfranc injury? I don't know what is decipher Lisfranc injury.
Basically, how to diagnose this hidden Lisfranc. Hidden Lisfranc. It is basically weight-bearing dorsoplantar and 30-degree oblique AP.
Okay.
But dorsoplantar. And also the lateral.
I have said that is the 20-degree cephaloid.
It is bad. Basically, you have to put a 20-degree oblique block below the foot, so that once you shoot 20-degree oblique view, then only you see you have to shoot at the first and second. Yes. So this is first and second. So basically, this is a foot block is there. Unless you have that foot block, you cannot make it 20. Then you cephaloid view for 20-degree at the first and second. Then only, so 3 views. One is the dorsoplantar weight bearing, second is the lateral, and third is the 30-degree oblique, and fourth is the 20-degree oblique, keeping the foot 20-degree dorsiflexed. Am I correct, Anjanda?
Correct.
Okay.
Yeah,
there is no other questions.
Just to add, this has to be a comparative view between the right and the left, between both.
Yes, yes, obviously. That is the greatest point Indoda has added, because you have to calculate the other side, see the other side, unless you cannot judge where the first and second, because you have to draw 2 lines from the lateral side and the medial side of the first and second.
Especially the ligamentous Lisfrancs, they are very problematic to diagnose. I remember one case, there's a lot of dilemma, and we had to do the comparative X-rays to look at the alignment of the metatarsal second to the intermediate cuneiform to diagnose that ligamentous Lisfranc. So it's very difficult unless you have comparative X-rays. Exactly. With that, Ananda sir, I think can we move on to the case? I think I finished off. Dr. Anjan Pan, can we take one case quickly?
I think already it is more than 2 hours.
Yeah, it is. We have crossed the limit. So is there still, if there is one case, we can discuss another case. It's the last case, I think. It is.
Anjan Pan sir, your last case. I'll stop screen sharing. Yes.
This 35 years male patient fall from height while making puja pandal. Injured in right foot, pain, swelling, ecchymosis present in right midfoot. Initially apply less Jes fixator. in distraction and wait for 3 days for definitive treatment. This is the Jex fixator, and then we put these after 3 days. I first put this K-wire from the medial cuneiform to second metatarsal base, and then first metatarsal to second metatarsal to hold this one, and with the clamp also to reduce this fragmented fracture. Then I put one screw from the medial cuneiform to intermediate cuneiform and one from the medial cuneiform to second metatarsal base. After that, I thought that this comminution is too much. So I removed this medial cuneiform screw, and then instead of that, I put one plate there from medial cuneiform to first metatarsal base. And I hold it like this. This is the thing.
Sir, if you can go back to your previous X-ray, just after the injury X-ray. Sir, can you go back to injury X-ray?
Yes.
Injury X-ray. Sir, yes, so thank you. Sir, I would like to ask you at this point, what were the thoughts going on through your mind at this stage? Did you plan for any, because this seems to be a comminuted fracture, did you plan for any CT scan, something to plan out your treatment?
I thought about the CT scan, but he is a very poor chap. For that reason, I don't go for the CT scan. We have to do by X-ray and this fluoroscopy assessment and other things during anesthesia.
Because I think, sir, there is a fracture per se of the C1. The C1 itself is comminuted. And I think the screws...
for that reason, I am putting that plate.
Yes, because your screws in that area, comminuted area, could not have had any hold, any purchase in that area, because it seems pretty comminuted.
Yes, right. For that reason, first I put the screws, and then I change that one and put the plate there, so that it holds the medial cuneiform and first metatarsal in the line.
And you have put the plate on the medial side, if I am correct, not on the top.
Yes, I am putting the plate on the medial side.
Sir, do you think one plate would have been sufficient in this area, or could have been a double plate, one on the dorsal side, one on the medial side?
Yes, actually, the good thing is, that the fragment of the medial cuneiform, it is basically the medial cuneiform fracture. So there is an intercuneiform instability and then medial cuneiform fracture. That is the main brunt of trauma here. That is the main problem. That is why he added this medial sided plate. That is okay. But see, if you see on the there is the space between the second metatarsal and this the medial cuneiform, that is almost a little bit maintained. So there is no the Lisfranc injury is not significant enough in this case. Basically, it is a major injury is on the medial cuneiform.
Medial cuneiform.
Yeah, that is basically is a fracture of the medial cuneiform. So that is why he did the right thing, I think.
So I think yes, completely agree with Professor Pal. This is a classic of medial cuneiform, more or less burst fracture. So this has to be plated, and this, if you see the proximal fragment of if you see the fast X-ray, the just post-injury X-ray, there is a big chunk at the base of the cuneiform. So if you just put the plate, it will one screw will hold it properly. I think plate is mandatory. That's why this has been done beautifully.
Yeah, but the problem is
as there is a plate sign is there. There is a plate sign is there. For that reason, I put that screws there.
Yeah, that is right. But Dr. Pan is right and is lucky, because there is a combination is not significant. If the combination is significant, then that will be a very problem to put the plate on that. So in that case, either
then we have to put the dorsal plate also.
Yeah,
then also you have to put the dorsal plate. Yeah, there you have to supplement with the dorsal one. Otherwise, it is difficult to hold this fragment.
Yes, that is what I was saying. Put a plate on the dorsal side, put a plate on the medial side, and then you fix your first M1 to C1. That would properly would have been a good osteosynthesis in your case, but a stable osteosynthesis. And then you go shift your attention to the M2 and C2. Maybe you can put a screw from the M2 to the C2 to hold it in that position.
Another option.
Or a home run screw from the one.
Yes, there are significant comminution. Then we have to the bypassing this. We have to first have to open reduction and or close reduction accurately to maintain the length of the medial cuneiform. Then we have to bypass. That is breaching that bone. We can reach up to the navicular also. From the first metatarsal, we can reach up to the navicular. So that in that, if there is a severe comminution, otherwise it is a right thing. Rightly he has done.
Another sir, if you see there is the medial fragment is quite a big piece. The C1, the medial cuneiform has a big piece. So I think that will have enough space for to hold one screw.
That is why he is lucky enough. That is why he put one screw from the proximal fragment to second metatarsal, and another he is able to plate the plate on the medial aspect, holding the first metatarsal to the distal component, proximal component.
There is not much of place there to put another screw.
Yeah.
It's just that you can use a big medial plate with or without navicular, depending on the fixation part of it, and restore the medial cuneiform and the first metatarso cuneiform joint. And then having done that, you can put in a second screw, or just a single screw in the traditional one going from the second cuneiform to the metatarsal. That would take care of the flex sign and the disruption of the Lisfranc ligament. And that big plate on the medial side would take care of the cuneiform fracture as well as stabilizing the first metatarso cuneiform bone.
Sir, one of the, you can see all the screw orientations that we have presented here are the Lisfranc screw is going from the medial cuneiform C1 to M2 base. But in there are also published reports that the screw can also be placed from the M2 retrograde to the C1.
No.
By Professor Vinod Panchavi.
That is. I have a lot of cases there also, but I don't put that one. But nowadays I am putting the screws more from the second metatarsal base to medial cuneiform.
Sir, I'd like to point your attention to the cuboid. Do you think there is a nutcracker fracture of the cuboid? Because there seems to be a radiolucent line through the body of the cuboid. Ananda sir, if you can see also there is
that may be a possibility.
Lateral also could be a missed fracture.
Yes, there is an irregularity on the yes, there is a possibility.
There is a line through the body of the cuboid.
Exactly.
That is why it would have been the CT scan would have been so helpful, but then the economics dictate.
This is where we are limited. Sir, if you can show your final fixation. Okay, so this is your final fixation.
Yeah.
Sir, your home run screw is going from the plantar to the bit dorsal aspect. So that's a bit protruding on the dorsal surface of the M2. So do you think it is a cause for concern in any way for us to learn?
Not because of this comminution. So I am not putting the screws from the dorsal surface. So, sorry. So I have to hold this proper bone position so that I have to put this from little bit plantar to dorsal.
Also, sir, your screw orientation is from the metatarsal base M1 to the M2. It is not from the classic C1 to M2 base. It is not in that direction.
That is from C1, this one.
Yeah, your home run screw, I mean.
That is because of this combination of this medial cuneiform.
Yeah, it could have been a bit proximal, I mean.
But the length is maintained.
Yeah. Length is nicely maintained.
Length is maintained. You have not done anything for the lateral side, sir.
No.
Lateral side, okay. It seems nicely reduced. Okay, I think Ananda sir, if you can wind up this session, I mean.
So it is very, very nice session we have observed and we have learned a lot. What is the Lisfranc ligaments, what is the Lisfranc injury, and what is the Lisfranc fracture dislocations, and there is what are the variants also. and what are the occult fractures to be looked out, and what are the red herrings. So how to diagnose, where to very much index of suspicion, and always we have to compare the injury along with the normal side X-ray. So this is very, very important point to be taken from our senior Dr. Sergeant Dr. Shaddar, and also the tricks for tips for fixation is extremely important. So we have to rigidly fix with a robust fixation, as robust as possible on the medial column as also on the lateral column, with some temporary fixation which should be removed as early as possible, at least after three months. And another important point is we have to, the post-operative period is extremely important, so that we should allow the movement not before 6 weeks. So partial weight bearing followed by, and that partial weight bearing should be continued for another 6 weeks. So there is no full weight bearing before 3 months. It is an extremely important message for all of us to be followed for better functional outcome. And there are also complications we have to discuss. So this is the first part. It's very, very interesting session we observed. And if we have another time, we will again gather together to discuss about the complications of the Lisfranc injury in another evening. So thank you all the panelists, and thank you also for the partner or the over to Dr. Nirmalo for giving thanks to our organizer.
Sir, I think there's one quick question from the audience, and he asking whether it is necessary to countersink the screw heads. And
Definitely.
It is necessary.
Definitely.
If you have a skin issue from the Amitabh sir's case, I think it is absolutely necessary in the metatarsal dorsal cortex. When you are using the screws, do countersink them, because the skin there is absolutely thin and friable. So do not leave the hardware prominent at any stage. So do countersink your screws, plan your fixation accordingly, and have the countersink ready in the operating table. Do not forget that. Sir, I think we will take a quick remark from our senior panelist, Dr. Indrajit Sardar sir, Dr. Swarnendu sir, and Dr. Anjan Pan sir, before we close this session and with the organizer. One quick comment beginning with Indrajit sir.
Yes, I think this has been an excellent session. This is the sort of session we wanted. We didn't get last time. And I think this has been a great learning experience for all of us. And this is a fracture, which I said, which is misdiagnosed. I hope we don't miss any. And when we diagnose them, we do the right things at the right time. So that is the whole part of this. It may be a minor fracture. We may not get too many cases of it. I remember in the 1990s in SSKM Hospital, I was able to get 12 of these cases, and I presented it somewhere in the West Bengal Orthopedic Association. I don't remember exactly. But those days, we only had X-rays and KY fixations. I lost the slides. I told Nirmal, if I discover them one day, maybe we can show some of them. That's it. I think this has been an excellent session. And thank you, everybody, for presenting such cases. We missed Kushal today really badly. But I think with the discussion was super.
Thank you, sir. And we have come a long way from the KY fixation. I must comment on that, sir.
Exactly.
We have really moved on. Okay, over to Swarnendu sir. Sir, your quick comments.
I think it is a less addressed injury in the foot, as because you know that Indrajit sir told us, because during our time probably we have been less focused on this sort of foot injuries. So we are basically learning, and now we are stressing these injuries in the meetings so that our juniors don't miss it. So thank you very much. Even I today learned many things from you people. So really it was a great learning experience for me. Thank you, Nirmalo and the team.
Thank you, sir. So Anjan Pan sir, your comments, sir.
It is a good session, but it is mostly we have to emphasize on to know the disease and the treatment. So because a few years before also, we are not very aware of this disease, as Indra said. So this is the most important thing of this. Thank you very much.
Thank you, sir. Thank you for your excellent and excellent take-home message from Anando sir. So I think this will be a great learning effect, and I think it will profoundly impact our practice, and we will change our outlook henceforth when we look at these kind of injuries. So it will make us more aware and more alert to these kind of injuries and the way we treat them. So that in general, the principles have to be maintained. You have to follow the principles of fixation. The debate is about whether fusion or ORIF. So that is according to the literature. You go according into the literature. And I think some of the tips have been clearly pointed out by our senior panelist members who are present here. So the take-home message is very clear to us, and we will keep more such sessions coming up. And in the meanwhile, I'll thank Ranbexy, our sponsor today, for this excellent webinar. And is anyone around from the pharma side to make a quick comment?
Thank you, Dr. Dev. This is John Major here.
Yes, please proceed.
By the way, Ranbexy is no more. We are Sun Pharma now.
Oh, great!
But it was an honor to host all the luminaries of Kolkata here, sir. It is always been an honor, and we are there always. If you need any time, we are there for you.
Okay.
Thank you very much. Thank you, Dr. Sardar. Thank you, Dr. Samanta. Thank you, Dr. Pal. Thank you, Dr. Anjan Pan. And obviously, thank you, Dr. Nirmala.
Thank you very much. Thank you.
I think it's a learning process. Thank you and enjoy your evening. Thank you, sir. Thank you.
Thank you. Thank you. Bye bye. Take care.
Bye. 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 Take care.
Bye bye. Bye bye.
Recording stopped.